this time, if there are any questions from the audience, if you will step to the microphone and direct your question to the appropriate panelist. We'll start with you in the middle.
Thank you. Again, the name's Martin Ornelas with Real Incorporated, Rural Transit District, 9 counties of the Coastal Bend. I think in part of the discussion, as I heard at the end, it's towards 5310, and from a transit provider, 5310 is the smallest pot of money. I think from our perspective, the verdict is still out, whether on this new definition of the provider, traditional, non-traditional provider, was the right decision, because as you know from a policy perspective, the one who controls the resources controls the discussion. And in such, the question that I have as a transit provider within the 5311 program is, how do we merge, merge is not the right word, align cultures of transit and healthcare to recognize that transit, as we are integrating ITS technologies, are dependent on us knowing our pickup time at the front end and the back end. And if any of you can control when any doctor tells you it'll be an hour, it will be an hour, it really places unintentionally a huge problem for transit providers, that our complaints, not of our own doing, go up, because we have not just dialysis patients or customers, every other customer that goes to healthcare, and the expectation is that we're waiting in an area where we have 240,000 people to serve with a fleet of 80 vehicles, that we're waiting by the phone for the calls. And so that challenge is a huge challenge. While we're trying to do innovation, and I applaud everything that's being done because we're doing parts of it, how do you find this cultural alignment by institutions and systems that could benefit not just healthcare, but also transit and improvement for ultimately, which is the customer?
Anyone want to try a shot at that?
Just real briefly.
Global question.
I mentioned our new satellite clinic, where it takes an hour to get from Sioux City over to South Sioux City, and it's about less than 10 miles. And it runs hourly. So if I have a patient come and I'm running late and I don't get them out within an hour, then they sit another hour and then have to ride the bus back another hour. So it's like a 4-hour trip for 10 miles. And so we're cognizant of that now, and we identify those patients that they are using public transit to get there, and we make a concerted effort to make sure we get them out in a reasonable time.
It's something that rural transit operators have been wrestling with for years and years: efficiency versus customer service, and the lack of infrastructure and resources to be able to be on-demand transportation, Uber, or more urban characteristics in its response. I have a question here, please, this microphone.
Hi there, Sneha Peck from America's Essential Hospitals. We've touched on this quite a bit throughout the day, but I'm curious, what's your opinion on the role of the hospital or health system in all of this? Who initiates that conversation? And how do we ensure that sustainability program for a long-term sustainability for something like this? And by that, I just mean, just as an example, is it purely financial investment? Is it collaboration? What are we talking about?
I think if you're going to really start with this, you need to start with the hospital's community needs assessment. And if they also participate in the community health improvement plan with the health department. But really, that's where you need to start working. And because the hospitals are required to participate if the community is talking about these needs. But part of the problem that a lot of community needs assessment plans and processes have is that the local people don't come out and talk about anything. We have been very robust in our community. The last time we did a community needs assessment a couple months ago, and granted we're only 172,000 population, but we had 10,000 people participate. But that took a lot of effort and a lot of community collaboration to get other people to participate and to really bring people to the fore. The other thing that I'm going to say, and everyone has said here, is data, 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 and more data. If you can show a return on investment, if you can show how programs work, if you can get cross collaboration, you can really get your hospitals and your health systems generally to buy in. But a part of that is that grassroots effort at the community needs assessment level, and it can't just be one person who comes to the focus group and says their piece. It has to be more than one person.
Okay, I'm getting my signals from the back of the room. I've got time for one question only.
Okay.
Real quick,
actually,
please.
Yeah, as Roy Grant, actually, this is more a comment than a question. I want to pick up on something that Dennis had said earlier about how does this get sustained? And we've been talking a lot about transit investments, private foundation investments, and the imbalance between the transportation sector buy-in and the health sector buy-in. Suzanne said something that, just sort of blipped by, but it's the kind of thing that's so crazy that sometimes we take it for granted. You said that a child or a person who has a diagnostic assessment for a behavioral health condition that is not covered by Medicaid and EMT. That's crazy. That's crazy. And that's because, rule out autism, rule out ADHD, rule out depression, rule out PTSD. That's a medically necessary visit. And to the extent that the most required transportation, medically necessary transportation system we have, which is the Medicaid non-emergency transportation, the idea that that's not being responsive to all medically necessary visits it's crazy. It's fixable by rational policy making. I don't think that we lack the data to show that if you diagnose depression and treat it, it reduces healthcare costs. We know that, especially for patients with chronic conditions. A lot of the ROI is already known, especially for adults with chronic conditions. It seems to me that if any of this is going to become sustainable, it's not going to be financed at the transportation end, and it certainly can't be financed by foundations. It has to be built into the medical reimbursement system, and that starts with getting a realistic look at what constitutes a medically necessary visit and making sure that transportation is required to be provided to facilitate access to a medically necessary visit.
And we will wrap up our session on that excellent point. As you can tell, ladies and gentlemen, this is a topic that we probably could have spent all day on just for this session. I want to thank again our panelists, our very knowledgeable discussants. At this point, we have a break in the agenda, and I'm going to have Alina.
Thank you. And an announcement. First of all, for those of you who are on the web, if you want to send a question, send it to me at the address that's posted right now. And then Hope is going to put out the next slide right there. So the breakouts, they're just two. And we're going to have Michelle Proser in this room. And this is going to be the DC area presentation. So Steve Yaffe, Annetta Arno, and Stuart Strauss. Sorry, I'm having a hard time remembering the names. And then in the other room, we're going to have, in the boardroom, which is just across the way, and Art Gazzetti. Where is Art? You were just there, so it's in that room, and that's going to be the Massachusetts area presentations. The folks from MIT and from Worcester, and Claire Randall is going to be in that room to help out. So see you in the breakouts. Thank you.